Thank you that
Sorry.
we record the call so that you may share the website with anybody who you know. We want people to feel comfortable to come back to see the content and have it at their fingertips. If only one of us is able to join on a night, we want it so that you have it when you're able to come together. We did a couple of updates to our website. I'd like for you to, Japs, take us to the top of the website, if you don't mind. And here, what we've done is come down and you'll see where we have AAHRI. You come down just a little bit, Japs, not right there. We are now removing the B from Bereave, and we are keeping the African American Health Reform Initiative. We're just removing the color. There may be some of us who like the black, but we're just going to keep it in for our culturally sensitive community. It's AAHRI. So if you plug in Bereave, you'll still get here to AAHRI. We have updated some of our resources on the website. And Japs, if you would take us through what those websites are so that we have it.
Yes. So first, on as a resource is our Black Health Matters. They are a great resource on online health promotions. Um, and they have a lot of uh, information there on healthcare from healthcare professionals, consumers, and patients. Next is Tiger Lily. It's a national women's health organization providing education awareness to young women. And next we have the Health Facts with Faith Community. And the other two that we recently just added are Everyday Health and Healthline that we have constantly used over the past. So you may click on the name itself or on the picture, and that will take you automatically to the website.
So we used to give quizzes and say, tell us if you've been to Everyday Health. Now you can come back out to AAHRI or Bereave and you'll be able to reach this information and it'll be at your fingertips. The next announcement is that we're going to make a day change in 2025. We are going to move from Wednesdays, fourth Wednesdays, to the fourth Tuesdays of the month. Oh, I see claps. We have heard people have activities, they have church, they have other meetings, and have not been able to join. And they wanted the fellowship and the opportunity to join the community. So we're changing that in 2025. Okay, so make a note of that. We'll continue to announce that. We also have an additional uh, adding to our group. We have added 2 doctors of nurse practitioners that are joining our calls and will be a consistent add to our community. They are not serving as care providers. They are serving as resources of information, sharing their knowledge. It's not to be diagnosed or anything. So these are friends and colleagues of mine that I have known for many years. And I'm going to introduce Cynthia Thompson and ask her to introduce herself today. Cynthia?
So thank you, Lisa, for the great introduction. So my name is Cynthia Thompson. I'm originally from New York City. And just to give you a little background, my father actually passed away with colorectal cancer. And that's how I got interested in this topic called cancer. Secondly, he did not receive the care that I thought he should have received. But unfortunately, I wasn't armed with information. Um, my background, 22 years in the military. I retired as lieutenant colonel. I was 12 years active, 10 years reserved. Went to school at a historical Black college called North Carolina Central, and then went to UNCG and did a nurse practitioner license and worked at Duke for 12 years in hematology, oncology, and solid tumors. Then I decided to get my MBA because I was just crazy and just loved school and called myself a lifelong learner. And I did that, and I got interested in pharma by speaking to communities like you and communities of underrepresentation of who we look like, what we look like, and what we need to be doing, and decided to, in 1999, to join a pharmaceutical company as a nurse educator in HIV and compulsive sarcoma and ovarian cancer and breast and multiple myeloma. But I had a extremely large territory as a nurse educator. And then I decided to go back to school, and recently I just completed my doctorate degree and did a thesis on why African American patients do not participate in cancer clinical trials. And I really went down to the communities of Washington, D.C. and got the real analysis and the real truth. And now I'm here with you today, and it's a pleasure to be here. You can ask me any questions. If I can't answer it, I'll say I don't know. But my ultimate goal is to one day have a forum like this where people can just go touch, and if they want to participate in cancer clinical trials, they can go right to social media and actually look it up, understand it, understand what they are, because there's still a lot of trust in the community and why people don't participate. And that's what we need to do. We need to continue for people to hear our voice, and we need to continue to have a consistent message.
Thank you, Cynthia. We are so honored and so privileged to have you. And I'll just let people in on a little secret. You were at the Washington Hospital Center when I first met you, and she was the director of nursing, or the clinic there. And that's how I met Cynthia, almost 20 years, 20 some odd, it's a
Time goes by
long time
fast.
ago.
Yeah.
And isn't it wonderful how in our community, we don't lose touch, we continue to stay in touch, and we continue to tap into each other's activities. So is Deb on? I can't see.
Now, Deb is not, she is unfortunately stuck in that hurricane in the Bahamas.
Oh, okay.
So she was on vacation, and then the weather is horrible there, so she could not get a flight out. She doesn't think she'll be able to get a flight out into Saturday.
Okay, excellent. So can you hear me now? Can you hear me? Okay, I want to make sure. I came off my headphones. Excellent. But Deb is another nurse practitioner residing in Virginia. She's down in the Virginia Beach area, and she will be joining us as Cynthia is there. Now, today our topic is about health screening. Why am I spotlighted? Oh, I don't want to be spotlighted like this. Okay, thank you. I felt uncomfortable just then. Thank you, Japs, for pulling me off of that. No worries. And we're going to talk about health screening. So Cynthia and we had invited Deb to be a part of this as well, but she can't join us. So we're going to start our topic now. If you'll pull up the slides.
You want me to pull them up, please?
No, Japs is going to pull it up for us. Great. So we thought it was important to just talk about basic screening and health screening and what those things are. And let's put it in presentation mode if you can, Japs, because I'm looking at the full thing, so I just see one slide at a time. But when you think about screening, we're going to talk about cancer screening at the end. We think about our blood pressure, we think about cholesterol levels, we think about urinalysis, we think about CBCs, we think about our eye exams, and we think about vision tests, we think about our dental checkups, we think about osteoporosis and the screening that's done for that. We think about immunization, our regular physical exam, our BMI, our skin checks, sexually transmitted diseases, all these things. This is what screening is. It's not just the things that we're doing related to a mammogram or a pap smear. All of this is screening. It's helping us prevent things when we can. So that's what we're going to focus on today, but we're going to focus on specifically cancer screening. So next slide, please.
Lisa, before you move on, just
Yeah.
let me say one quick thing about this. This is why we should have regular exams, right? Because if we know that we have high blood pressure, or if you have a blood pressure cuff, people say, oh, my blood pressure is fine. But this prevents kind of chronic diseases. Like if our cholesterol level is up, we might have a heart attack. And I'm just using this example. If our blood pressure is up, we're not getting enough blood to our heart, which ends up we have congestive heart failure. So the reason why we're saying is this screening, because there's a lot of individuals that don't believe in going to the doctor. We still have individuals in our community that says this is not important.
And we don't want that to be the case. That's why when we learn, we empower others to do better. So next slide. Oh, so tonight is the gala for Prevent Cancer Foundation. We had invited one of their members to do the presentation. So she shared her presentation with us. So we're incorporating their presentation with us today in what we're doing. So next slide. Better outcomes for your family, early detection and better outcomes. And this is sort of what Cynthia was saying about in general, but we know that if we do the things that we're going to talk about as it relates to preventing cancer, we know that we can have early detection and no cancer, or catching some cancer in the earliest stages, so it's not late stage disease. So those things are extremely important. We want to focus on the power of screening. And as you know, these slides will be available to you at the end of this, at the end of the call. Next slide, please. So I thought we'd use this interesting one. A lot of people don't think about screening because they're concerned about what does insurance cover? Do I do this? Sometimes you won't go, you hesitate. So this slide was provided by Prevent Cancer, and it talks about the ones that are covered by insurance: breast cancer, cervical cancer, colorectal cancer, and lung cancer for people of the highest risk. So these we know are going to be covered. And depending upon your medical history, there are others that may be covered as well. Next slide. So these are our routine cancer screenings that we should be thinking about, and thinking about, are they on our calendar for 2025? There's still a couple of months left in 2024. Have we done these? Have we scheduled these? Have we put these in place? Breast cancer for the women and men. You know, you're not going to get a mammogram as a man, but we are going to have the opportunity to have colorectal colonoscopies done, lung cancer screening, oral cancer, prostate cancer for the men, skin cancer for all, and testicular cancer screenings available for men as well. So Michael and Mark, you're going to have to carry the weight of making sure that there are other men that know, and all the women always know. We take this back to our spouses, our brothers, our friends to share. Next slide.
And Lisa, can I just say something about lung cancer?
Sure.
If you're someone that has a 20-year history of smoking, that screening is free. So you really don't have to worry about, like my sister smoked for maybe 40 years and her screening came free because the government has provided screening in 340B hospitals, those hospitals that you're probably familiar with, all of them just about are 340Bs. But you could now go get tested for lung cancer free. I just wanted to bring that up just in case you know that you know someone in your family that are smokers.
Thank you, Cynthia. You all see what a walking encyclopedia and a resource we have on this line with Cynthia. When we get Deb and Cynthia on here, we're in trouble, y'all. It's fired up. Next slide. Thank you, Cynthia. We found from Prevent Cancer this particular chart. I think it's a very valuable chart because we want to have an idea of when we should be doing things and what are the screenings we should be doing. And I like this because it talks about our age. The 20-year-olds, you got children, you've got parents, the whole gamut is here, and us. Those of us in our 60s, those of us in our 70s, those of us in our 80s. I think and point out this area first because you started doing some screenings and we always ask the question, do we need to keep doing these screenings at this age? Is it still worth it? Is it still worthwhile to do that? So this is what this shows. So I'm going to, the one I'd like to point out is the dental oral cancer exam. You keep doing it, right? So it's very important that there are cancers that can be detected by a dentist and upon oral exam. The same is true from your eye exam. There may be things that you can see. As you look at the cervical cancer screening, colorectal cancer screening, the ages for colorectal screening, it's not 50. If you look at that, that's age 45 to 75. And then at 75, you can start having a conversation with your doctor. I think when I think of being 75, I had my first colonoscopy at 40, because I had blood upon my fecal exam. I don't think that my physician, nor do I want my physician to tell me I'm going to stop at 70, because I still get colonoscopies every 3 to 5 years, depending upon what is found. Cynthia, want to say anything about that?
So yeah, I want to say a couple things. When we, because I think in our population, we get this confused. So there are what we call tests, right? That are called colon screening tests. My sister has never had a colonoscopy. I keep using my sister because this is important because I'm kind of the nurse practitioner family and I can't figure out why she can't figure it out. But she says, I'm not getting a colonoscopy because I'm screened. Well, that is not for prevention. She's going to a drugstore, getting the test, putting, the fecal there, mailing it out. And she thinks she's doing the right thing, but we need to have the colonoscopy. The reason why we sometimes have to get it early, like I did, because my father died very young of colorectal cancer. So at 40, I had polyps, 45, I had polyps. 50 and had polyps, right? So now I have to get it done every 5 years, right? So all that is really spelled out. Hopefully one day we'll have those resources on this site, when and why, because I think it's one thing to have these up there, but we need to explain the why, right? So like a clinical breast exam, I tell my daughter that's 21, you should be doing this, right? That's different from a mammogram. At 20, you should be really, now they're saying even earlier, but you should be, your primary care provider will be feeling for your lumps in your breast, but you should really be looking in the mirror 7 days prior, 7 days after the menses, right? Cervical cancer screening. Cervical cancer has really eroded because we're not teaching our kids how to go to the doctor at 21 and have a pap smear. And my daughter made something very clear, this 21. She said, you know that, Mom. But how many other people are being told this? And this is why it's so important that we communicate out all this information to churches, to barbershops, to wherever we can provide these resources, because they're very important. Another thing, when we look at cervical cancer, we have to think about HPV. There are certain viruses that we get that causes HPV that causes cervical cancer. So if we're not screened, we don't find. If we don't find, by the time they get to the doctor, because cervical cancer is very slow growing, then it's already at a stage 4. And I'm going to stop there, Lisa.
No, I think that's great. I think, Crystal, thank you for putting your comment in the chat, and that when you were screened and that your sister had colon cancer. I think it's important that I also say this, that because I had adenomatous polyps at 40, all of you know Charles, and he won't be ashamed to say this, he's now 30. He needs to get his colonoscopy that early because of that risk. So these are the things that we need to know, and to continue to support one another and encourage each other, not to be fearful. If you need somebody to go with you to do these things, that's what we should be doing, helping and supporting one another. So we remove the fear, we remove the mistrust. Next slide. And we'll get into some of the details that Cynthia was talking about. Here's one for prostate cancer screening and skin checks and testicular cancer. If you look at this, the 20 and 30, I think that's 20 and 30. Go back, Japs, just so I can get the age. Yeah, 20 and 30. They don't have things down for males for prostate cancer, but you look at that age 50, and if you're Black, you start that decision with your, well, Black or white, but for us, we want to make sure that if you've got a precondition or family history, you start even earlier at 40. Next slide.
Lisa, can I just say one thing about that?
Mhm.
Prostate cancer. If you know why men do not like to have exams and do not like to go to the doctor, why do you think we have African Americans have such a high risk of prostate cancer and is diagnosed so late? What is one of the reasons that they're not getting their prostate exam? Does anybody know the reason?
I don't.
So the biggest reason is because they have to do a rectal exam.
Okay.
That is the number one reason why Black males do not go to the doctor, because they don't. But you can tell them that there's other ways that they can get their PSA checked, or they can have other ways to test for prostate cancer. So I just wanted to put that out there.
Yeah, that's a good one. Hadn't thought of it that way. It's just, you know, we get them, on our annual exam, so we don't think anything about it, but there is that sexual connotation that nobody wants to speak of. So it's a bigger deal. So thank you for pointing that out and making sure that we understand, or we know. So how about the next slide? So these are the greater details that we were talking about for colorectal cancer, and the details that we were talking about, the average risk, and what the American Cancer Society recommends is screening at 45, and knowing your family history. And Crystal, I'm going to point you out again, because thank you for sharing your family history and what you know. I now have a family history that Charles needs to know, and others need to identify and know what's going on. So, and if you're in good health, this is why age 75 is there. I'm in good health, but I have a risk, and I've had bad polyps during this time in my life, and that have been snipped and removed. So I will continue, but I will have that conversation with my physician as I get older. And it says people over 85 should no longer get colorectal screening. I wonder if I will be in that category, if I'm in good health. I think at 85, I'm going to be feeling fine. I'm going to go to St. Peter Baptist Church when I retire and go to their exercise class and do it on Monday, Wednesdays, and feel like I'm in good shape. So that's an important thing. Let's go to the next slide. Okay. So Cynthia, you were talking about other ways to get your prostate checked. And I think this is a good example of the types of things we can do for colorectal cancer screening and what the options are. And the fecal occult test that you do every year, the guaiac fecal occult test that's done every year. You have the multi-targeted stool test. Those are the type of exams that you were talking about with your sister that she gets, but she still has not had a colonoscopy. So these are just tests that would allow you to understand that there may be blood in your stool, but if there's no blood, that still doesn't mean don't go get a colonoscopy. My trigger at age 40 was that one of those, because I had a hemorrhoid, had blood in my stool. And my physician knew I better go. I better send Lisa, or she will get me if I don't have her go have a colonoscopy. So these are examples. So here, more frequently, you have the colonoscopy done, the flexible sigmoid how do you say that? Sigmoidoscopy? That's sigmoidoscopy. That's every 5 years. And then the virtual colonoscopy has become more popular. You've seen it on TV. If I remember, Katie Couric was one of the first people on NBC to do one of those. That's another way to put the little camera or thing down and follow it. So these are just examples of understanding the types of screening that are available to us. The blood stool sampling test, as well as the colonoscopy. Next slide. Here's the lung cancer. And Cynthia, if you want to talk about this one, because you started talking about the 20-year PAC history for cancer, I think it's important that everybody know about this low-dose CT scan.
Yeah, so the American Cancer Society just, I think this probably came out maybe about 10 years ago and said, hey, we're going to offer a low-dose CT scan. Because one thing, and I'm just going about my sister, she says, well, I get chest x-rays every year. But as you know, chest x-rays does not pick up lung cancer, right? It just shows some cloudiness. So they decided, they meaning the American Cancer Society, said, well, we have a lot of smokers, so let's offer these people that have either a 20 pack smoking history, right? And those people who are 50 to 80, let's offer this for them free. Now, my sister smoked, she was smoking since 13, and she's 68 now. And we talked about this. She actually developed breast cancer, right? And so, oftentimes we say, well, I smoke, I didn't get lung cancer, but we can get other cancers, right? Because we know, how does cigarettes get through your body? It's through your kidneys, right? You urinate them out, and then you can have other cancers. But this is what I was telling you, that sometimes people don't know this is available. You could talk to your primary care physician. Look, and they should offer this to you, but just in case you don't, this is a really good resource. You might hear somebody with coughing. You might say, how long have you been coughing? Oh, I have allergies, but really it's probably coming from the cigarettes, right? You hear somebody has a hoarseness. Do you have allergies? That's the first thing a nurse is going to say. No. Perhaps suggest this. I was listening to this podcast. I got some great information. Can I share this with you, right? And so now my sister quit smoking, but guess what she's doing? Vaping. Just as bad, right? But she says, I'm not a smoker. So I kind of leave it alone and try to just educate her on vaping. You're still you still, still nicotine, right?
Mhm.
But this is certainly a way that you can explain to some people that you know in your church or your sororities or wherever, you know, areas that you talk to people, you can just tell them, hey, this is free, and talk about the benefits, right? And some people might say, oh, I don't want to get radiation. Well, you get more radiation going outside than you do from a CT scan, just to let you know that, right?
Mhm.
So sometimes we have these preconceived notions because, like my mother, who's 86, 90, they kind of grew up on these old school ways and they don't trust physicians. And sometimes I don't either. So that's why we can come back and say, here are the resources from the American Cancer Institution. This is not from us. This is what they recommend.
Yep. And it's a trusted source. So
Correct.
thank you. All right, next slide. Breast cancer. Here's one near and dear to everyone's heart. It gets a lot of attention and advocacy. Women ages 40 to 44, we know they should start their annual breast exams. But I think before we do talk about our the breast screening, I think that we need to talk about the fact that you can do self-exams. You have to be aware it's nothing wrong with in the shower or having a spouse check your breast, or to know that it's not anything that is bad to do your own self health exams. And notice there are women who will tell you, that's how I found it. I found something and that sent me to get this to be examined. So be very comfortable with what you're doing. So we're looking at how often, when do you start, and how often you should get your mammograms. So we know that there is the 45 to 54 range now that you're looking at every year. We also know that there are the for high, the what is it, the density of your breast, if it's a
That's
higher
correct.
density, right? You want to have a different exam and not run away from it. It's a good thing. It may cost a little more, and many insurances are covering that now. And I think as long as we are in good health, and we know, and I like the way that this puts it in this slide, you're going to live 10 more years. I think most of us on this call know we are. Then we know we should be continuing to have our mammograms and have our breast examined so that we can catch things. And Cynthia, help me out on this one. I know that as long as we live, we're going to be exposed to estrogen, right? It's less, but over the years, we all have an increased risk of having
So
breast cancer, period.
so when you go into menopause, you're not, that's the whole idea. If so I'll give you an example. So once you hit menopause, estrogen goes away. That's why we have osteoporosis.
Mhm.
Estrogen's supposed to diminish, right? If you are secreting too much estrogen, you hear terms like ERPR positive, right? We're
Mhm.
not supposed to have estrogen after menopause. That's just a rule of thumb. That's why we lose elasticity in our skin, our face. We start getting a little tummy. That's all because of estrogen, right? We don't want too much estrogen because it causes cancer. Now, everybody in my family except me and my mom has had breast cancer. But me and my mom and my one sister, we have benign adenomas because we have dense breasts, right? So when we talk about this family history, that is the family history that we're talking about, right? When we talk about that genetic tendencies, we're talking about things that you are born with in your chromosomes that you have no control over, right? But there's also other factors. For example, I'll give you an example. Robin Roberts never had a baby. That puts her at risk because she wasn't able to get rid of estrogen. And when we have a baby, that's what we do. So she was just constantly always secreting too much estrogen. If you start your menses before the age 11, and we know women are, that puts you at higher risk. If you eat more saturated food, that put us at higher risk. If as we get older, we call it a little tummy, but however, that's fat in that little tummy. We know that that puts you at certain risks. If we smoke, if we drink, we really can't do anything, right? But I'm just saying these are environmental factors that put you at risk. If you're working around, you're parking a lot of cars and you're a male and you're in the garage all the time smelling, gas fumes, that puts you at risk. So there's certain things in our environment, there's certain things in our family history, but what we do know is we don't want estrogen as we get older. And that's why we have osteoporosis and all these other diseases, right? Because we are older and our body just changes as we get older.
Okay.
So hopefully that's helpful.
Yeah. Thank you, Cynthia. I'm going to pause for a second. Any questions? I see the chat, Crystal, thank you for putting things in. Do you have any questions before we continue? I want, us to get to your questions at this point, and we'll keep going with other examples of screening as well. If there are no questions, I'll keep going. I didn't see any hands. Oh, okay, Juanita, yes.
I just have one quick question. Dr. Thompson mentioned drinking, and there some of us every now and then like a little glass of wine. And, sometimes they've said, okay, one glass of wine for a woman is not a problem. You shouldn't have more than one. Then sometimes they say, no, you shouldn't have any. So thoughts on that?
So I think the thoughts on that is do everything in moderation, right? When they talk about that, that's like an everyday drinker for you've been drinking since the age of 13 and you continue to drink. One of the reasons why they talk about drinking, because guess what drinking has? A lot of sugar.
Sugar. Mm-hmm.
Sugar turns into fat. Fat turns into obesity. Obesity is one of the main factors that's associated with breast cancer. So that's why I say sometimes we have to understand the whys, because all the doctors do is say, don't drink, but they never tell us why. They just go on, okay, well, he's just a doctor. But they never pull through and say, why not? Explain the why so that I'll be able to give that knowledge to the next person and the next person. And so that's what we talk about, everything in moderation. How do we get rid of sugar? We exercise, right? I'm sitting here exercising on the sofa, right? Because as we get older, our body gets sluggish, right? So that's what they're talking about. Just like something on TV said, don't drink no more than 1 cup of coffee a day. Now they say in the American Heart Association, if you drink 3 coffees a day, you live longer. So as we study medicine and as we get into clinical trials, why it's so important, because we have to study the whole entire population. We can't make a generalized statement on if you only study 4% of the population, that's for everybody, because everybody's body is different, right? Does that make sense?
Yes.
Yeah.
Thank you.
Crystal, ask your question. You put a question in the chat. Are you able to come off mute?
Yes, I am.
Okay.
So, don't people try to get extra estrogen to relieve hot flashes when they get older?
The hot flashes comes from what? Menopause.
Mm-hmm.
You see what I'm saying? So that's you exactly right, and that has been linked to cancer, but they're not in full-blown menopause. They're going through menopause symptoms. They're relieving the symptoms, not the estrogen. So they're giving extra estrogen because theirs is low, right? They're feeling the symptoms from it being low. So they're bringing them up to the level to deal with the symptoms, not the cause. So yes, it makes sense that some people do take it because, you can go into a crisis, menopause crisis. So that's the ones that get the patches. But trust me, when the beginning of menopause and then at the end, they'll get some relief because finally they will be rid of the symptoms, right? So that's why they get the estrogen. Does that make sense?
Yes and no. So you're in full-blown menopause after you don't have a cycle for a year. Is that accurate?
No, that's not accurate. You can no, you go get tested. And what happens is you tell the doctor, well, I haven't had a cycle in a year, right? So first of all, we got to figure out, is it ovarian cyst? We got to figure out the cause. right? If the cause is the menopause, which they can do a test and say, okay, you just started menopause, there's a blood test, right? Then they say, I want you to come back in a year or two. If they don't see any polyps or ovarian cysts, right? Because I had ovarian cysts and I had a cycle all through my pregnancy, right? But I knew it was ovarian cysts. So we can't say that. We always have to figure out the cause first. So they will do a test and say, hey, this is what's going on with you. You're in menopause. If you can't deal with the hot flashes and the symptoms and the irritability that comes along with it, I want to give you a low grade patch or some injections, right, to make you feel better. So the symptoms, right, that you're having doesn't interfere with the quality of your life.
Mhm. Yep.
Okay.
All right. So let's go on beyond breast cancer. And these are the types of screening that are done. Clinical breast exams, we talked about the 2D and the 3D. That's the latest one for the dense breast, and then the MRI. So I think that those of us with dense breast or a history of a baseline of the MRI is something I've had done for that reason. So you can always have that baseline. It's not the most comfortable exam, but it's the discomfort of that MRI, the peace of mind that goes with it is worth it. It was for me, just to know, with my mother who has had breast cancer. So that's important. These are just examples. Next slide. Prostate cancer. And Cynthia, you started this off the right way in terms of African American men are more likely to have prostate cancer, and they are definitely going to have it in a later stage. So more and later. So it's important that men are getting their PSA blood test done. And that's something that you were mentioning right away, that you just need to start knowing your PSA so that you can know whether or not you have benign hyperplasia of the prostate. You know, there are other things that can cause the PSA to go up, but just having, like we have breast health sense, prostate health sense is a very important thing. And knowing that as an African American male, that you should be talking about this in your 40s so that you're ready to make sure that you're doing these rectal exams and PSAs and getting all of this done at the right time, and knowing getting your uncles and cousins to talk about these things so you get a family history is very, very important for Black men. Start talking.
And so, Lisa, I just want to add to that. So I've been in the military, and the military is now even asking, because they're exposed to so much and they go overseas, that the test actually starts a little early at 40. But what do you think, if you were thinking the number one reason why men do not want to take anything is kind of like women, and they will not have surgery? You could put it in the chat. What is the reason after we find out we have prostate cancer, why we don't want to be treated?
Impact on sexual performance.
That's correct. That is exactly correct. And that's a conversation. If you're 40 or 45, you can see the difficulty. You're married, maybe never had a child, right? But we understand giving these hormones reduces our what? Testosterone. So that's why it's so important to tell a male what happens and what can we do, right? Because before it was taboo, we never talked about it because, sometimes in our culture, we just didn't talk about it. But this is the reason why you see so many males, more so than whites, our counterpart, they're dying early of prostate cancer. Mm-hmm. Because that's what causes prostate cancer, is testosterone, right? So we have to get rid of the testosterone. And to get rid of it, it's either surgery or hormone therapy. Mm-hmm. So you're exactly right. I just wanted to point that out, that there's plenty of organizations like Zero. You can go to the sites, you can point your friends to the site, to understand and have a conversation about sexual health, because that is extremely important in males.
Thank you for Zero. Japs, make a note. Let's add Zero's website to our site, please, for male health and prostate health. Okay,
Okay, will do.
thank you. Next slide. So here was an interesting topic that maybe we'll end on this, but there are lots of infections that are linked to cancer, and then there are vaccines that can prevent some of these cancers. So Cynthia, you talked about HPV, and the human papilloma virus, HPV, causes cervical cancer, vulva cancer, anus, penis, and head neck cancer. And it's a virus, and it shows that it's also it's a virus. And then you look at hepatitis B. We all know about HPV. We know about hepatitis A, B, and C. You see here that virus is associated with liver cancer, as is HCV, liver cancer. And then there is the Heliobacter pylori. That one is associated with stomach cancer. Then you have Epstein's Barr, another virus, and that one is associated with cancer of the nasopharynx, and Hodgkin's disease, which is a blood cancer, and non-Hodgkin's lymphoma, another blood. And then you have the herpes virus associated with age, the Kaposi's sarcoma, that whole syndrome around age. And then we have others, the human immunodeficiency, HIV, and that's the same thing up at the top I'm talking about. And then you have your T cell virus there that's associated with leukemia and lymphoma. Schistosomes in bladder, and then liver flukes and the bile duct cancer. So there are a lot of infections. So there are things and ways we can prevent them or test for them. So for the HPV vaccine and all of those associated, you have a HPV vaccine for younger men and our women. It's an opportunity for us to teach our children's children at an early age that they need to get this vaccine to help prevention. Also, hepatitis B vaccine, as we see, and we can do 2 tests, the H. pylori test and the hepatitis C test. Those tests are critical in terms of prevention. So that's a lot, but I think that we need to become aware and want to know more about the vaccines that can help prevent things. We're going to get to a place where there are going to be there are also vaccines that help with treatment of cancer, but we're not going to talk about that. We're just talking about screening and prevention and the things that we can do to catch things early to have better outcomes.
So Lisa, I do want to say something about hepatitis, right?
Okay.
So grew up in the 80s or the 70s, there was a big heroin use, and you see that it's coming back now. And people are saying, well, why pass out needles in New York City, right? Why pass out needles? It's because that's, is blood, right? If you share a needle with someone else, we're susceptible to hepatitis, Kaposi's sarcoma, HIV, right? That's one of the diseases that it causes. So if we're trying to prevent something, people are going to use drugs regardless, right? Whoever we are. But we do want them to use clean needles. We don't want them to use it all, but if nothing else, use clean needles. These might be the same people that's handling your food, right? We don't know. I'm just saying that if we're talking about prevention and we know someone has a drug habit, that's why they pass out needles if you still have users. It's not because they think it's right, but it's kind of like, okay, what do I want to do? Do I want to help this person? Yes. But are they being susceptible to more diseases like HIV, like hepatitis? Because there's no cure for hepatitis. We can only treat the symptoms, right? So that's hepatitis C. Let me make that clear. So that's kind of when we think about prevention, and we think about heroin use that's coming back into the forefront. Those are some of the things that we have to talk about.
Thanks for that, Cynthia. That's great. Next slide. I'm going to, because it's 7:22, I'm going to continue to get through it, but if you need to jump, I understand. We try to keep it to 45 minutes, but acknowledging we're over, but we'll continue. Cervical cancer is another important cancer to talk about. And with cervical cancer and knowing it can be caused by HPV virus, we know that now there are ways to prevent that, and women should start thinking about that. So when you think about screening for cervical cancer, it's one of those at the younger age. So I think as older women, we need to support and help our younger women to help them understand what they can do about prevention of cervical cancer and to be comfortable with what they can do, and making sure that at this age, they know they can take should have taken the HPV virus, and to ask and to tell them to tell their boyfriends and sons they too can take the HPV vaccine for different reasons, but that's exactly what you want to do. Head and neck cancer. I mean, we may not get to head and neck cancer, but with oral sex taking place, you can get head and neck cancer from that. So having the HPV vaccine available to us will prevent that as well. So I landed on that with this, but people over 65, who have regular cervical cancer testing in the past 10 years with normal results should not be tested for cervical cancer. Have that conversation with your clinician. But it's like, if you've had positive health and you have not had a problem, you should not feel at a point at 65 that you still need to be tested if you still have your uterus and your cervix. So, but I always say have a conversation, but these are the guidelines to know. When you reach certain age, you want to know if you should or if you shouldn't. These are things to help us there. Okay. All right. Next slide. Endometrial cancer. So this one, you just don't know about these symptoms. They sneak up on you. It's you have to know your history, the biopsies. So it's really something, I think, because it's not clear. The symptoms aren't evident. It's just something to have conversations about with your healthcare provider. So and that's at this time we were talking about menopause. This is when you really need to start thinking about this endometrial cancer and what takes place. So start having those conversations. And thank you for putting it out there that it's increasing with Black women. And that's because we don't have these conversations around menopause and saying we want to understand more, what should we be looking out for. And if you're having the spotting, if you're having bleeding, don't let your clinicians put you off. Know your body and your health and advocate for yourself and say, let's talk about this. Okay. Next slide. I like to keep this one, we've got a lot of melanin, but skin cancer, melanoma. I am a person who has had 3 of these little abnormal ones, and I get full body skin checks. And I have used the ABCDEs, of skin cancer to do it. Just because you have brown skin, don't think you don't need to use sunscreen, and don't think that you don't need to go to dermatologists, and don't think you need to be aware of the moles that we get on our body. So please pay attention to your skin and what can happen with it. And even if your pigmentation is darker, you still can get a mole and it can grow and look irregular. So, skin cancer is the #1 cancer. Okay. Next slide. This is another one that's important. Oral cancer screening. It's like oral health is important health. So everybody, let's make sure, there you go for heart disease. Yeah, you can find out many things about your oral health and dental health. I was learning recently about diabetes and teeth decay. So, just those things that are important to us with our health. Next slide. This is what we want. We want everybody to have a healthy life, live a long time. Early detection and prevention is what we wanted to land on today. And we thank you. Thank you. If you have questions, please, put them in the chat. We'll take the slide down. We'll pull up our gallery view. And if you have any questions or any comments or things you want to share, now it's your time.
Lisa,
Yes.
you mentioned the ABCDs of skin cancer. What does that entails?
Oh, so let me think of what they are. It's about the irregular detection. I'll pull it up real fast. Do you know it off the top of your head, Mark or Alicia or Cynthia?
Asymmetry, color, border, and diameter.
Diameter. Yeah.
That's in reference to the spot that you're seeing, how it may or may not change.
Yeah.
If it's asymmetric, if the borders look a little not distinct, there you go, color, diameter, and there you go. All right.
Who pulled that up that fast? Japs?
Japs.
Yes.
Yeah.
Japs, you're the bomb.com. I tell you, thank you, Japs. There you
You're
go.
welcome.
Take a screenshot if you want, Belinda, or,
And that's what I'm trying to figure out how to do that.
So you got your phone, pull your phone out and just take a picture.
Okay.
I'll make sure to add a like a PDF file of the ABCDEs of the skin
thank
cancer.
you,
Okay.
Japs.
Okay.
That's
Thank
great.
you. Thank you
you.
so much.
No problem.
Yeah. See, Johnny on the spot. We can have what you asked for. I love it. Thank you so
Mhm.
much. Any other comments or questions?
Lisa, I want to make a quick comment since I ran my mouth there. You all know it's also good to see you all. I'm just going to make one quick comment. On the slide where Lisa was demonstrating the viruses, and there's a number of them, and I know that it could feel overwhelming with all the information you hear. It's a lot to monitor, a lot to manage, and you'll notice that many of these things were acquired, right? So as you're living your daily life, as you're socializing and where you go about, you're coming in. So you'll notice that most of those weren't airborne related. So it's not like a COVID where you can inhale it just in your everyday. This is interaction. Black people in particular, we're social, we're communal, we want to be around each other. And most cultures already have a degree of that. So as you live in your life, you're exposed to these things. And back to the very point, do not miss the point here. You may not remember all of that, right? But the point is to go to the doctor, go to a professional you trust, or at least have an advocate so that you can have support, so that you can screen regularly and be checked, so that you can get these indications or these observations early and not end up in a late stage situation as Dr. Thompson talked about. Whereas when you get there, you're already way down the road. So it can feel overwhelming. It was a fantastic presentation, a lot of information. If there's anything you take home, go to the doctor and tell each other to go. And support one another. Because when you hear a brother and sister say, I don't go for whatever reason, say, stop right there. If you're afraid or if you don't trust the doctor, call Lisa Moreland over. And she can connect you with people who love you, who look like you, who live to support you. So please, please, please stand in that gap. Each one teach one. Love y'all. All right. Thank you.
Thank you.
Wonderful. Yeah, thank you, everyone. You know, we do love you, and this is important to us. Thank you for joining, giving us your, hour-long, but I hope you will join us next month. Japs, what's our topic for next month? Do you recall?
So for next month, let me pull it up.
Okay, that's perfect.
Bear with me.
Mm-hmm.
We have our topic is about, did you schedule those screenings?
Ah, so we're going to check on you. So what is it that what is it that you're doing, or are you doing those things? And that's a great opportunity to, I think we plan that because October, aren't we, those of us who have to enroll in Medicare and do those kind of
Yes.
things, it's time to think about your plans and what it is you need to do. And then others of us, we still have 2 months left in the year to get some things done, get your physical done if you haven't done it, and get these things scheduled. So thank you, everyone.
Thank
You
you
have a
so much.
great evening.
Great presentation.
Okay. All right.
Thank you, Lisa. Thank you as
Bye-bye.
usual. Thank you for
Thank
your
you.
subject matter experts.
Yes.
Wonderful.
Thank you.
Oh,
Thank you.
great. Thank you so much.
Thank you.
Thank
Good
you,
night.
Cynthia.